مع تقليل المواطنين.
Assalamu alaikum. Today we have a presentation about a project already conducted in the University of Iowa. It's in the same department I was in, the pharmacy practice department. The principal investigator in this research is Barry Carter, which is one of the investigators in pharmacy practice and science, University of Iowa in the United States. The title is It's a cluster randomized trial of physician-pharmacist collaboration model to improve blood pressure control. Before we get started and go deep to this study, we need to give some introduction about randomized control trials or control trials in general. What do we mean by clinical trial? Clinical trial is a prospective trial, prospective experiment. So we need to follow up the patient in the future. So we need to have two aspects. We need to have prospective follow-up and we need to have intervention. It's not observational study. The difference between trial and observational study, this one has intervention. The other one, observations, it's like the survey one, it's only observation. But in this case, we should have kind of intervention, whatever. So, for example, it could be new treatment, or new procedure, or new surgery. In this case, we will have behavioral intervention. So, as you know, the recruitment of patients doesn't have to be all at the same time. When I say prospective, we can't start recruited patient just not like from now. We can recruit patient over 3 or 6 months. So we keep recruiting patients. It's not like single time, we need just started March 1st and everyone should be recruited in March 1st. No, that's not right. We can still keep recruiting patients, like it's up to maybe 6 months or 1 year, it depends on the study. So the prospective study could take, it's up in this study, it took like 3 years, this prospective study. While the interventions took like 2 years, 24 months. So they have 1 year of recruitment. Clinical trials, as I mentioned, the gold standard for clinical trial is randomized control trial. We should have randomization. We should have control group to compare our results. So this is the gold standard, it's randomized control trial. For example, if we have new treatment, we need to test this new treatment. We need to compare the results of the new treatment on the volunteer. We should have volunteer and participant. We need to compare the results of the new treatment on the volunteer against control group. Control group could be conventional therapy, could be placebo, could be nothing. But we always need to have control, so we can say, compared to the control, the result of the intervention group is higher or better or more significantly higher. We always need to have control. Without control group, it's weak design. So we always say randomized control trials. I will go over the randomized in the next slide, but we need to all these items. We need randomization, we need control groups, we need trials. It's a prospective study. If I say prospective study, you imagine it will be expensive, it will be time consuming, it needs so much resources because you need to follow up those patients or participants in the future. And the main challenge in this case will be the drop-off because you will lose some of those patients that will not come back to you. This is the main challenge for the prospective study. While a retrospective study, you just go and collected the medical charts. You don't, the information already there in the chart. But the prospective one, you may miss those patients. They may drop off in the way. At the end of the study, you may have, if you have large percentage of drop off.
Rate of escape.
Yep. So this will decrease the validity of your study. That's why the main concern of researcher is the drop off. Ethics in clinical trials. As I say, those are volunteer. Usually the study principal investigator pay them kind of incentives. But we still need to do our part. We need to take ethical approval from the university. And we need to tell them all the risk, if it's physical risk or whether it's psychological risk, social risk, because we need to tell them all the risk, and they should be aware about the risk before they sign the consent. So we need to make sure they know all the alternatives. For example, the control group. Control group, if they have hypertension, we cannot leave them without treatment. We usually keep them on the conventional therapy, which is the regular therapy, not the new one. So there are so many ethical principles here, but we also need to take care of them if there's something wrong happen. We need medical team. If there's something wrong happen to those participants, we need to take care of them. Like in case of emergency, we may say your hypertension is not under control. They may need emergency, so we need to stop the study and take it to emergency. So keep in mind, those are human, even they are participant, voluntary participant, but we still need to take care of their health. The simple design of randomized control trials, we have groups of participants. Randomly, we assign them either by the computer or randomization, other randomization method. You say you have here, we have 7 or 8 participants, say, by computer will choose. Say, the first 4 here go to the treatment group, the intervention group, and the other group here will be control group. We'll follow up both groups in the future. This one with the new treatment, intervention. This one with the conventional therapy or placebo or whatever. At the end, we need to compare the results. So after we compare the result, we'll decide if the new medication is better or lower quality or whatever. So we need to follow up those 2 groups in the time, and we measure the results at the end of the study. All these should be documented. We should know how many patients we enrolled in each group and how many patients left. And we need all these, and we have too many details. I don't want to go to those details now, but maybe later if you have questions. So randomized control trial here, the key point here, we need to have intervention group and we need to have control group. So we can compare the results of those 2. Patients are randomly allocated. Why do we need a randomization? We need randomization for 2 main reasons. Number 1 would be minimize selection bias. If I don't use randomization, somebody will come to me and say, okay, you put the healthy people in the intervention group and you put the people with poor health in the control group, and this is biased. So I need to minimize this selection bias. Say, I will not choose the computer or whatever, they will choose for me. So this is to minimize the selection bias. Number 2, we need both groups that are comparable in the gender and the age. So I will not decide it by myself. Randomization will try to put, so I will have comparable group at the end of the day. When I compare those 2 groups, I will say they are comparable demographic data. And I say, as I said, the computer can randomize them. So another principle in the randomization trial, there is blindness, at least single blindness. What do we mean by single blindness? The patient or the participant, they don't know which group they are going to be assigned. So this blindness will avoid also another bias. So we need to have control group, we need to have randomization, we need to have blindness. Okay? Because we don't need those patients to know if they are in control group or intervention group. Because if they know they are in control group, they may behave differently. If I say this, you are taking placebo, say all this capsule placebo, why I take it? They may not take it, or they behave differently. So they don't know which group they are assigned. They behave. They say, I don't know which treatment you are taking. Just keep taking this medication until the end of the study. So the participant, they don't know which group they are belong to. So if we have all these criteria, we'll end up with high quality, standard quality. will end up. So the studies say randomized control trial is in the top of the pyramid of the study. It's better than cohort, better than cross-sectional, which is like survey, case control or case series. So it's in the top of the design because it's a strong design, minimize all the bias, try to control all those. That's why I say it's gold standard. They use it for all the new medications. Blindness. There are two types of blindness. Either it's single blindness, which is, as mentioned, the participant, they don't know their groups. Also, double blind, which is better, even the investigator or the researcher, they don't know. Why? Because I don't want to take care of the intervention group better than the control group. So double blind, it will be even better. And you will ask me, say, if the patient, they don't know group, and the researcher, they don't know the group, who will take care of the results? Who will collect the results or the data? There will be third party. Third party will, for example, biostatistician or nurse or whatever. They will collect the data, so you will not be biased. Because if I will be the investigator, if this is my study, and I'm collecting the results, I may be biased a little bit because I will say, okay, this is intervention group, I need to take care of them because I need them to have better health, to get better results. So we need to eliminate all these kind of bias. So double blind is really also helpful, but maybe we cannot apply this to all studies. Like in our today's study, it's single blindness, it's not double blindness. I will mention that later. Why this study, Dr. Barry Carter study, it's a clusterized randomized trial. When I say cluster, when I say randomization, you imagine I randomize patients into two groups. Is that correct? Into intervention group, control group. But the cluster, we need to randomize the setting itself. For example, the hospitals or the clinics. We will choose settings or hospitals. They are intervention group, and the other hospitals or clinics, they are intervention groups. You will ask me why we don't make it in the same hospital. For example, Baghdad Hospital, and within Baghdad Hospital, we randomize patients between clinics. I will answer that saying, if we don't do cluster randomized trial, we will end up like in the same hospital or same clinic, and we have control patients and we have intervention patients. We will have kind of, they call it contamination. What do you mean by contamination? For example, I'm the physician for the control group, and my colleague, Dr. Samer, is the physician for intervention group. When we sit together, he will talk about intervention group to me and say, I will do this for my group, I will increase the monitoring. I will hear from him, I'm start applying what he is saying to my control group. So my control group will get better health because what? Because by indirect way, I'm applying the intervention. I'm like that because we are the same setting. We are colleagues, so we exchange information. To avoid this contamination, we need to make sure this control group is not contaminated with intervention group. So they decided to do a clusterized, randomized trial in this one. If we do just randomization trial within the same setting, we will end up, we call it type 2 error in biostat. What do you mean by type 2 error? Which is false negative test. We will have, we say there is no significance between those two groups. Why there is no significance? Because the control group will have the intervention. So I cannot find significant. This is negative false test. So this type 2 error, maybe in biostat, it's really important. We cannot rely on the just person randomization. We need to make sure we are doing cluster randomization. This study conducted in the University of Iowa pharmacy practice sites. It's a study conducted over 3 or more years, and it's really they got really good grants from NIH, from U.S. federal governments. And as you can see, this team, it's really interdisciplinary team. because we have from College of Pharmacy, College of Medicine, and we have biostatisticians from College of Public Health. Because in such big research, we need everyone participating, contribute to the results. And usually we need biostatistician in such complicated randomized control trial. So Barry Carter is the principal investigator, and Chris Coffey as well. The acronym for this study is CAPTION, which is collaboration among pharmacists and physicians to improve outcome. Now we call it CAPTION. So I may use acronym CAPTION to refer to this study. This study, why I chose this study? This study, it's not just randomized control trial because the methods, but also I chose it because to prove the pharmacist-physician collaboration that will improve patient health. Which patient here? We are dealing with patient with hypertension. So the inclusion criteria was patients with uncontrolled hypertension will be included in the study. Patients with controlled hypertension will be excluded. So this is the inclusion criteria. The objective of this study, the study is already implemented in the same objective before, but for this stage, they have 3 new objectives. This time, they need to implement it in a large number of medical offices. They chose 32 offices across the US in 15 states. They say we can implement this nationwide. Had sustained effect once it was discontinued. They will start the intervention for 9 months. And they say if this intervention, after I stop the intervention, after I stop the pharmacist intervention, is the control of blood pressure continue or the patient blood pressure deterioration? I will continue for 9 months. I will follow up after 9 months. See if after the pharmacist stop monitoring, is there something, what's going on after this 9 months? Also, they need to measure it among minorities, like Latinos or African American, because it's important for them to get this grant. I think it's a good minority. So it's a prospective, multi-center trial in 32 medical offices. Those offices, they include on-site, they include a clinical pharmacist. We have outpatient clinic physician, and the clinical pharmacist sitting with the physician in the same clinic. They have his own room or whatever. So we expect there will be collaboration because they work in the same setting together. Also, a subject assigned, as you know, this is informed consent. We need informed consent. We need ethical approval before we get started even. This is the simple the diagram of this study. We have 32 clinics. Randomize those clinics into 11 clinics with 9-month intervention. This intervention number 1. Intervention group number 2. We have 2 intervention groups. Make sure we have 1 control. For those who came late, we usually compare the intervention against the control. In this case, we have 2 intervention groups. We have 9 months intervention, we have 24 months intervention. Here we have 9 clinics, 11 clinics. Usual care, which is the control group. Usual care, we mean by usual care, it's without pharmacist intervention. Pharmacists still working on the side, but they will not do anything for the patients. They just sitting there, not intervene. This is the difference between control. And they follow up those 3 groups. This is the whole diagram, which is kind of, I know it's not clear because it's really huge. The point here is the control group. This is the control group. It's without any intervention, okay? The 9-month group, they discontinue the intervention after 9 months. For the second intervention group, which is 24 months, they continue the intervention. So we have 24 months intervention, we have 9 months intervention, we have control group. All those, we follow up those 24 months, 2 years, okay? But for this group, we discontinue the intervention after 9 months because we need to compare after this discontinuation what will happen. Is it still like, are those patients still doing fine, or this group will be better? So the method is both intervention groups were designed to receive identical intervention, both groups, for the first 9 months. We have the second group, we call it the sustained intervention group, which is continued 24, while the first one discontinued after 9 months. The control group received what? Received the usual care. Usual care means without pharmacy intervention. They were receiving their medication. They were receiving their physician. They visit their physician, but they didn't receive the pharmacist intervention. And as I mentioned, this study was approved by University of Iowa Institutional Review Board, required before you start any human-related research, you need to take approval from this IRB. In inclusion patients, any patients speak either Spanish or English well, so they can communicate with them. They have interpreter for Spanish people, and should be above 18 and with uncontrolled blood pressure. Methods: clinical pharmacy service. What will happen? What happened in the pharmacy clinic? We have 3 groups. We measure their blood pressure at baseline, which is the time 0, after 6 months, 9 months, 12 months, 18 months, and 24 months. Okay? To avoid contamination, the pharmacists working at the control group, they were told, don't talk with the patients, don't answer their questions, unless the physician asks you some questions, like you answer them informally. So control group, pharmacist, without pharmacist intervention. What pharmacists did? Pharmacists included medical record review and did structured interview with the participant. They took the medication history, assessed knowledge of blood pressure, medication, dosage, timing, potential, assessment of other barriers to blood pressure. So the pharmacist had 2 roles. The first one, sitting with the call, usually sit face to face. Try to answer all the questions, try to assess the treatment, try to find out if those treatment appropriate or not. So they try to sit with the patients, and the part 2, if there's any problem, uncontrolled blood pressure, they contact the physician, mostly face to face because they work in the same setting. So they have 2 roles, one directly with the patient, the other one directly to with the physician. The second role here, so what the pharmacist did, telephone call at 2 weeks to follow up, then face-to-face visit at baseline, month 1, 2, 4, 6, and 8. Or we have different timing between pharmacist consultation and blood pressure measuring. Remember, blood pressure measuring was 6 months time. So this kind of not exactly the same, but this is physician, pharmacist, patient meeting. Okay. The recommendations usually of the patients focus on the medication educations, improving adherence, which the pharmacists try to improve adherence to medications. Like if the patient is was not taking the medication appropriately, they try to convince them to take the medication on time. So we need to keep the adherence high. Because as you know, if we have low adherence, patient doesn't comply with the medications, they will not have good result. So the pharmacists try to increase the adherence. Scoring clinical pharmacy, this is survey. We distributed survey and try to score the pharmacist action, which is not part of the result, but we just need to do what's going on. We always can do survey. We can do survey for pharmacists, for physician. This is kind of. So we survey, we try to score the pharmacist action. This part is the second role of the pharmacist. The pharmacist and physician try to collaborate. But the key point here, these recommendations they are not required to be accepted by physician. So the pharmacist send recommendation to the physician, but physician say if they agree or not, it's not part of the study. So they don't force physician to accept the recommendation.
Optional.
Optional. Why? Because they need to make it effectiveness, not efficacy. Try to make it like daily life activity. They make it and we are in the daily life. It's not like experiment, because in the experiment it will be ideal condition. But in the daily life, we may have agreement, we may have disagreement. So let's say we have tried to imitate the daily life. It's up to the physician if they whether accept or reject the pharmacist's recommendation. The goal of the blood pressure was depends on the case. If it's an uncomplicated case, the target was less than 140/90 millimeter mercury. For those with diabetes or chronic kidney disease, they should be lower because those with complication. So this is the target. After we measure the blood pressure, we can decide if this patient controlled or uncontrolled. Okay? Depends on these values. Who were measuring the blood pressure? The pharmacist was not measuring blood pressure because we need to avoid what?
Bias.
Any bias. We don't need the pharmacists themselves measure the blood pressure because they may have bias, you know? So they assigned a group of registered nurse, licensed practitioner nurse, and medical assistant to measure the blood pressure. They use this machine, Amron AH device, whatever. They try to take two measures when the patient's sitting, two measures, and they take the average of those two measures. So there was a third party responsible. This team came to the Iowa. They across 15 states, but they came to Iowa to be trained by the same personnel. So they will not have variation among them. They came to University of Iowa. The research paid for them for travel. So it's really a good funded study. That's why they paid for them to do the measuring. So we'll minimize any bias. Study coordinator. What's study coordinator role? There was another party who was coordinating this, the results, the measurement, like supervisor, who is not part of the pharmacist, to avoid any bias. So the coordinator tried to supervise the measuring of blood pressure at this time, baseline, 6 months, 9 months, 12 months. And as we mentioned, we have two measuring. We usually take the average of those measuring. And also those study coordinator took the demographics of those patients or participants, height, weight, pulse rate, durations, or the kind of confounding factor. Any factor tried to influence blood pressure, they measure it, or they took it. Medication adherence measure, it's 1 to 4 item, and it should be in the appendices, but I didn't look to the appendices, and it's 0 to 1 mean better adherence, 2 to 4 is poor adherence. I think there is another measure for adherence, Moresky.
Yes.
Yep, Moresky scale is really popular, and I heard that Hawk University now they have
8 items.
translated version, and they can. It's not free, but I'm not sure how they charge us. But data analysis is kind of, we have more than one outcome to measure. We have primary outcome, either controlled or uncontrolled blood pressure after 9 months, okay? This is the primary. And these are the numbers. And also, we have secondary, for the primary outcome, they use kind of complicated statistical analysis. I don't want to go over it now because it will take more than one lecture. They call it nonlinear mixed effect model because we have for participants, we have offices. So we have kind of two lines. We have participant within one clinic and we have multiple clinic. So they use this mixed method. With logistic regression or logit, because when we use logistic regression, if we have binary outcome, binary, in this case control and control, we use logistic regression. They use the link for logit here to measure the observed actual data against these assumptions. Other one, last observation carried forward. Like for example, if we have measuring at month 8 or 6, and we have missing at 8, 9, we can consider the month 8 measure, month 8 measure are the same as 9. They can say carried forward, okay? So with last observation carried forward, we consider the same value. This is still, it's not that, so we need to do sensitivity analysis all the time. Secondary objectives, we need to compare the two groups of interventions against the control group, okay? Also, we need to see, we have two intervention groups, one with 9 months, one with 12 months. We need to see if the patient's blood pressure still under control after we stop the discontinue compared with the group B has 20 months, 24 months intervention. So we need to say if there is any difference here. Also, one of the objectives was related to the minority. How is the response of the minority against majority? They recruited half minority, half majority. They try to make it fair here. As you can see here, non-Hispanic Caucasian, it's like almost 50%, minority almost as well 50%. So this is kind of demographic data for the participant. Gender educations or all confounding factor could influence the blood pressure. The table is really long, but I just got it. Baseline blood pressure, we have at time 0, we measure the baseline blood pressure. This is brief. This is 9-month intervention, sustained 24 months intervention, and control group. The results. Because we have third party who took care of the measurement without any bias, we end up with non-significant difference between intervention groups and the control groups. حسيت تقول هذول ماخذين 5 ملايين جرانتس وبعدين طلعوا non significant results. Like showing it's almost significant, but the difference here is not significant between the intervention groups, the two intervention, and the control group. It's almost significant, and it's better. The result was better. As you can see, the control, the intervention group, they have 43% of the participants under control. While the control group, they have only 34 of the participants where their blood pressure were under control. So we have better results, but still the difference was non-significant. And they gave all the explanation and justification. We don't have time to mention why they were not significant here. If we adjust the mean systolic diastolic, if we have adjustment according to age and other factors, we end up with significant difference or significant reduction. What happened for the third objective? The odds for blood pressure control for minority subject in the intervention group were significantly better than the control group at 8 and 24 months. So this blood pressure control for this is just for the minority. It's significantly better than control group at 18 and 24 months. So for control here, it's for minority is better. In conclusion, we couldn't find significant difference between groups, although we have improvement in the control of blood pressure. This improvement due to the intervention of pharmacists, collaboration of pharmacists with physicians. The pharmacists work over 2 years or 9 months with the patients, try to increase their adherence, try to explain their medications. And also they work and they provided recommendations to the physician, try to control blood pressure. So this intervention seems helpful, and we can implement this collaboration nationwide. Although the difference is not significant here, but we still have significant improvement For the mean blood pressure and control rates seem to be deteriorated in non-minorities. After we stopped the treatment, we have two intervention groups. We have 9 months group, we have 24 months group. After we stopped the intervention, the blood pressure deteriorated, mean increased. So that means we need always intervention, so to keep the patient under control. Continuous. Otherwise, once we stop the intervention, the blood pressure will be out of control. So the take-home message from this seminar is, or this study is, we need to establish such team-based care model. We need the clinical pharmacist to work side by side with the physician, try to manage and control patients' blood pressure. So all this money didn't go away without benefit. The message here is say the physician-pharmacist collaboration could improve patients' health, could control blood pressures, and we will end up with better health outcome. Thank you so much, and I'm ready to take any question. تفضل.
بس بالنسبه للكنترول جروب قالت انه هم ريسيف اليوجوال كير which not include يعني pharmacist intervention.
نعم.
يعني is it
ethical؟
لا مو بس ethical يعني is it يعني هو هذا البراكتس يعني بامريكا انه not receive pharmacist intervention as a usual care؟
حقيقة yes. يعني هم هاي for experimental purpose they put the intervention. We hear usually about the contribution of pharmacists, clinical pharmacists, but they don't have their position. They usually try to convince the physician. يعني بين قوسين احنا نسمع الهالة الإعلامية انه الفارماسيست بس ترى نظامهم تقريبا بعد يشبه نظامنا. يعني يجوز كندا يجوز افضل، الدكتور سلام يمكن تحدث عن الموضوع. كندا يستدين طول الفارماسيست يكتب بريسكريبشنز او بعض الاماكن، مو كل البروفنسز، بس بالولايات المتحده بعدها يشبه وضعنا، انه عندك هو الاوثوريتي كلها بيد الطبيب، والصيدلي عاده هو ديسبنسر بالصيدليه. انا اقول لك عندهم اوثوريتي الصيدلي لانه عنده ريسبونسبيلتي، اذا لقى ان ابروبريت ميديكيشن بالوصفه ما يصرفها، عندهم يوقفها ويتصل بالطبيب، ومرات ياخرك يقول لك تعال يومين بين ما نتصل بالطبيب. هاي الاوثوريتي اللي عندهم. بس ما تقول لي هو ديلي اكتيفيتي، هم يصرف له 300 وصفه باليوم. هذا الصيدلي عندهم هو الصيدلي واقف 8 ساعات او 12 ساعه على رجله، عنده بس نص ساعه بريك. السلام عليكم. نص ساعه بريك بس، حتى الستول ما يقدر يقعد. استريح هنا محمد. فما لا تتصور انه حيقدر يسوي كونسلتيشن طويل. هو واقف على رجله وعنده كل 5 دقائق لازم يملي 3 وصفات، والوصفات لازم يشيك الانتراكشن مالتها ويسوي لها باكج. فيجيك طبعا هم required by law in the US الفارماسيست do consultation only for new prescription. اذا refilling ما يسوي له consultation، يقول له يعني مو required by law. هو required by law شنو؟ بس اذا new prescription يجيك الصيدلي يعلمك على الانستراكشنز ويقول لك do you have any question، على السريع يريد يروح لانه الدنيا مقلوبه يمه. فلا تتصور انه هم الديلي مالتهم انهم فانسي وهذا، لا، هم اليوجوال كير هو ماكو انترفنشن. هسه بالجديد او مو بالجديد يعني صار فتره عندهم كلينكس يصلحوا له ميديكيشن ثيرابي مانجمنت. يحاول الصيدلي ياخذ له فد كورنر بالصيدليه ويقعد المريض وياه يشرح على الادويه، ونفس العمليه يسويها هنا. هاي بس لازم يستلم عليها فلوس. هاي فقط ادمن من يدفع فلوس، هم هناك ما يشتغلون مو بفلوس. من يدفع على فلوس؟ فقط الميديكير هي المسؤوله عن الالدرلي 65 years old and above patients. فدول الوحيدين يدفعون هذه الخدمه. فهم من يسووه فقط لل 65 سنه وفوق. ان الناس الشباب والصغار جو 65 ما يقعدون وياهم لانه ما مدفوع على حسابهم، ما مدفوع. الريكونسيليشن والفون كول هذا كله اذا ما مدفوع ما يسووه، لانه يعني الساعه مالته $60 الصيدلي من يدفعها؟ انا اقعد ربع ساعه ويا شو اسمه من يدفع لي؟ فهناك بس الام تي ام من يسويها؟ بس الميديكير يدفع لها. فاليوجوال كير انه اليوجوال كير ترى ماكو ذاك الكونسلتيشن يمكن بس ذولا جماعه الميديكير، وهذول مره كل 3 اشهر او كل 6 اشهر او حتى مره كل سنه. فلا تتصورها انه عندهم هم يعني بعدهم دا يعانون. هم كلمه هيلث كير بروفايدر يريدون يحصلوها الامريكان فارماسي اسوشيشن، مثل عندنا نقاط الصيادله، من اني هناك دا يسوون كومبين عليها، وهم عندهم بيروقراطيه، وهم عندهم الكونغرس يوافق وما اعرف مجلس شو اسمه يوافق. ليش؟ لانه من ياخذ لقب هيلث كير بروفايدر يقدر يسوي بلانك، يقدر ياخذ فلوس على اتعابه. حتى الان ما محصلين هذا الستيتس، وانا سويت واحد من بحوثي على هذا الستيتس يعجبكم تشوفوه، على البروفايدر ستيتس. كلهم بده يقولون احنا نريد بروفايدر واحنا متحضرين، بس ما حد ينطوهم هذا الستاتس، لانه من يحصلوا معناها يقدرون يحصلون فلوس على الخدمه مالتهم. يعني بعد ماكو استشاره مجانيه الصيدلي، يجبر الهيلث انشورنس تدفع فلوس مقابل كونسلتيشن. حقيقه جود كويشن دكتور. لا ثانك يو. بعد منو عنده سؤال؟ تفضل استاذ دكتور.
كلينيكال فارماسيست
دكتور نعم.
كلينيكال فارماسيست اختاروهم للدراسه.
اي
يعني دربوهم قبلها لو هم بس اليوجوال يعني النولج مالتهم؟
سووا لهم سيشن مثل ورك شوب، على تكونوا يعرفون يحكون نفس الحكي ويصير يعني هم من يسمون تيم ورك. بالضبط. خذ سؤال ممتاز السؤال دكتور اسامه. عاده هناك من عندنا هيك تيم بيست ريسيرش، هناك يجمعون كليتهم مثلا انتم احنا 5 بالريسيرش، لازم نحكي نفس الحكي، ومثل ما تفضل دكتور سامر اذا تحكين حكي مختلف حصير بايس، انت مال المرضى مالتك انت تعبين وياهم وانا ما اتعب وياهم، انت تحكي لهم شيء اضافي وانا ما احكي لهم شيء اضافي، طبعا تاثر على الريزلتس. فكلنا نحكي نفس الحكي، ناخذ نفس الفورمه، ناخذ نفس الداتا، ونسوي نفس الريكوردينج، ونفس يعني الخطوات نفسها، عم تمثل اي بايس. ليش هسه انا اقول لهم الطلاب من نسوي سيرفي، من نسوي اي شيء، حاول انه تسوي تراين للتيم مالك كله، يعني اكو واحد احتمال يشتغل من ورا خشمه، واكو واحد لا. فهاي يعني حقيقه هم يجمعوهم باليونيفرستي اوف ايوا، قلت لك دفعوا لهم مصاريف عندهم قلت لك فوق $1 مليون استلموا جرانت من الحكومه الامريكيه على هذا الستدي طوال 3 سنوات من 2010 الى 2013، طبعا استمرت بعدها، فعندهم خوش فلوس فقدروا يدزون عليهم ويشترون ما يجوزوا يسوون ترايننج.
بس من كانوا ضمن الدكتور؟
اكو عندنا حسب السنتر اكو كانوا 2 بالسنتر مالتنا مال ايوا، كانوا 2 من قسمنا، هذول عندهم لايسنس فارماسيست، هذول كانوا هم من ضمن التيم مال ايوا. بس احنا 15 ولايه لا تنسى، 15 ولايه، كل ولايه الصيادله مالتها، فما نون كونفينينت تطير الطياره وتسوي كونسلتيشن، لا انت لازم تاخذ اون سايت وتدفع له راتب ذاك الصيدلي، تاخذه مثل استعاره. بعد تفضل.
Thank you for this informative lecture. I have actually 2 questions. First question is, should we reassign the participant if we have major differences in the age and the gender? For example, if we make a randomized groups, we will have randomizedly female more in the control group and male more in the...
It's really good question.
Should we reassign the...
It's really good question. There is another part, I didn't mention it. It's kind of complicated. We call it stratified. Stratified. That means we need our groups to be gender equal. We need, like, that's why we distribute according to the gender. You know, I need like, this group has 10 participants. I need 5 female and 5 male. So in my randomization, it will be specific randomization, not like I will end up 9 female here and just 1. It's a good question. We call it stratified. We need to make sure we have gender equality. Even for the age, we have kind of this. So it's really, the randomization is not that easy. That's why it's need to be done by statisticians.
Before لازم قبل الدراسة نسوي
the baseline as
شنو ماكو فرق بالمجموعتين لازم.
Baseline characteristic here, as you can see, they are comparable. The age try to be comparable. So randomization will take care. Stratified randomization will take care of your concern.
Okay. The second question is about adding a line to this study by, as you said, ideal conditions.
No.
To make a legislation for the pharmacist to force the physician to.
If you make it master agreement.
Another group, a side group.
Yeah, but because as you know, there are 2 terms. One called efficacy, one called effectiveness. The difference between those 2, efficacy is in the ideal world, yes, while effectiveness in the daily world, on the real world. We need the effectiveness. Because in our daily life, we don't have perfect collaboration between pharmacist and physician.
I know, I mean...
there is no advantage of adding something ideal in the non-ideal world. So they try to make it effectiveness, actually, over the efficacy.
They study the significance of making the pharmacist doing the recommendation.
They don't care about biostat. Even it's non-significant here, but they still improvement. So if they need to make it biased or something, they can make it significant easy. But they have honesty, they have all these measures to make your result non-biased. Look, it's non-significant. The result after all these millions was non-significant. This is a good message for us and for you grad students. You don't have to get significant results. It's okay to have non-significant because you conducted the study, you conducted high quality study, and you will end up with non-significant. No worries. Don't say I need to be significant so I get published. I know I agree with you will be published biased. Some journal they say I will not accept your study for publication if it's not
Only
significant.
positive result.
But at the end of the day, this results get funded, get published. So it's a message for you. You need to get high quality or high standard and let this results like without any bias. أكو أي سؤال يعني آخر؟
بس نتائج محبطة يعني الفارماسيست انترفنشن
لا مو محبطة هي أكو
improvement بس not clinically significant.
أي بس على clinical significant. clinical significant.
Statistical
not significant. فرش سؤال. يما النتائج مو محبطة. ما محبطة لأن النتائج متقاربة كلش. وأنا ما أسوي لهم دعاية بس يجي. شكرا لاستماعكم.
شكرا جزيلا.